Greetings everyone, I'm Dr. Ketan Barjatia, 5th year DRNB Neurosurgery resident at Bangalore, and today I'll be discussing antiplatelet in acute ischemic stroke. Antiplatelet form the backbone of medical management in acute ischemic stroke, but the timing and choice are absolutely critical. In most patients who do not receive thrombolysis, antiplatelet therapy should be started as early as possible, ideally within 24 hours of symptom onset. The most commonly used drug is aspirin. A loading dose of 160 to 325 mg of aspirin is given, followed by a maintenance dose of 75 to 100 milligrams daily. Aspirin works by irreversibly inhibiting cyclooxygenase, thereby reducing thromboxane A2 and platelet aggregation. Now, in selected patients, especially those with minor stroke or high risk TIA, dual antiplatelet therapy can be considered. These usually involve aspirin combined with clopidogrel, started early and continued for a short duration, typically 21 days. This strategy is supported by major trials like CHANCE and POINT, which showed reduce early recurrent stroke risk. However, prolonged dual antiplatelet therapy is avoided due to the risk of hemorrhage. Now, an important caveat: if the patient has received intravenous thrombolysis with altiplates, antiplatelets must be withheld for at least 24 hours and only started after a repeat CT scan exclude hemorrhagic transformation. In patients undergoing mechanical thrombectomy, antiplatelet strategy depends on whether stenting is performed, but aspirin is usually initiated within 24 hours if there is no bleed. Another key point: antiplatelets are not a substitute for anticoagulation in cardioembolic stroke, such as atrial fibrillation, where anticoagulants are indicated after the acute phase. So, to summarize, early aspirin for most patients, short term dual therapy in selected minor stroke, and strict caution after thrombolysis. Used correctly, antiplatelets significantly reduce early recurrence and remain a cornerstone of acute ischemic stroke management.